right. Well, thank you for having me. Let me get pulled up here. 1 second. So my name is Cody McNeely, and I'm going to be here speaking to you all about some considerations for our male patients when it comes to osteoporosis. Can everybody see this screen okay? Okay. Um, so just to tell you a little bit about myself. So my background includes receiving a bachelor's degree in psychology at the University of Kentucky in 2007, and then graduating with a doctorate in physical therapy from UK in 2010. I initially worked with patients in an inpatient rehabilitation setting, so seeing many patients post-op after falls and fractures. I've been specializing in pelvic health since 2012 and obtained pelvic rehabilitation practitioner certification in 2020 through Herman and Wallace Pelvic Rehabilitation Institute. I'm an adjunct lecturer for UK's Doctor of Physical Therapy program, and I am currently the clinical coordinator for pelvic health in Central Kentucky for the Upstream Rehabilitation brand, which includes Results, Benchmark, and Dreyer Physical Therapy clinics. So a few things that I want to just talk about this morning. So we're just going to kind of lay a bit of a foundation for understanding osteoporosis, some risk factors, and then some unique considerations for male patients, and some interventions. All right. So just a little bit of a review here, taking a look at osteoporosis. So this is a condition that is characterized by decreased bone density. Let's see here, make sure I'm still. So it results in decreased strength and more fragile bones. As you can see in the illustration here, it leads to abnormally porous bone that is more easily compressed, and that causes weakening of the bones and results in frequent fractures. Very commonly, those fractures will occur in the spine, hips, ribs, and wrists. So with incidence of osteoporosis, in the US, approximately 10 million Americans over the age of 50 will have osteoporosis, with 34 million additional people being at risk of this disease. And so I feel like generally we hear about osteoporosis more in women, but much less in the frame of its effects on men. Looking at this kind of second point here, the statistic kind of helps us to see why perhaps more of our focus may be towards women, as we see that only 7% of the male population will have osteoporosis, compared with 23% in women. And if we left it kind of at that statistic and that knowledge, I might not be here today speaking to you about men. But if we take a little bit of a deeper look at the incidence of men who are actually having fractures, we'll see that that number is much higher, at 1 in 4 men over the age of 50 having these fractures. And so why is there this difference? So one contributing factor is that the fractures don't always occur when bone density is in the osteoporosis range. So in fact, 27 to 45% of the fractures in men actually occur in the osteopenia range. So, identifying people who are at risk of bone loss and earlier on, so that we can kind of catch these risk factors early, it's really paramount in aiding in prevention. Another major difference that we see compared to women is that when we look at mortality, men are higher in all areas. So 1 in 15 patients with a hip fracture who's 60 or older will actually die during hospitalization. And for men, that mortality is higher than women, so 10% versus 5%. 1/3 of those patients who actually survive the hospitalization will die within a year. And again, for men, that's a higher rate at 38% versus 28%. It has been found that male gender is an independent factor associated with mortality. And this mortality increase in men is likely associated with higher prevalence of comorbidities. So when we think about osteoporosis and fractures generally, and we're thinking about women, we're seeing that occur a bit earlier on because a lot of those changes happen in response to menopause and hormonal changes. So with men, it's fairly common to see that they may be older when they're having these fractures, and that typically includes them having more health and medical concerns. And then you'll see here men actually who have a hip fracture at a much older age have an 8-fold increased mortality risk during that first 3 months, and that risk persists for more than 10 years. So for many, this would be a higher risk of mortality throughout the remainder of their lives. So when we're talking about men, though, we've said osteoporosis is less common, fractures are quite common in men. And when they happen, it is a much more serious outcome. So to further understand some gender differences, I want to do a little review of pathophysiology just to kind of understand the role of bone microarchitecture and how that contributes to bone strength. So there are numerous components that you can see here to consider. So the first component that we're looking at here is bone size or bone mass. And that's actually a really major factor, which we'll talk about a little bit more. So we've got the bone size that is a contributing factor to strength. We have the structural properties or bone morphology, which is kind of the geometry and the composition of the bony material. And then we have material properties or the bone matrix, which includes the mineralization of the bone's cellular structure. So these are all contributing factors to bone strength. Taking a little closer look at bone structure and composition, you'll see here bone is composed of 50 to 70% mineral, 20 to 40% organic protein, 5 to 10% water, and then 3% lipids. And the mineral content of bone is mostly hydroxyapatite. So going back to our slide, and talking a bit more about bone mass. So this bone mass, which we said was very important, it actually accounts for 50 to 70% of the strength of our bones. Our other categories here of bone morphology and composition are important. However, because larger bones are stronger than smaller bones, mass plays a greater role in strength. As our bone diameter expands radially, the strength of the bone increases by the radius to the 4th power. And so while bone size and mass is kind of the major factor here, it is also important to consider our bone mineral properties, and they're important for our bone strength. So in areas where we have low bone turnover, this will contribute to accumulation of microfractures. High bone turnover with bone resorption greater than bone formation is the main cause of this deterioration within the bone. So when we're looking at bone remodeling, we're looking at a balance of formation of bone versus breaking down or resorption of bone. So taking a look at how things change as we age, in the first decades of life, the skeleton changes its shape, it grows, and our bone mass is accrued up to a peak. So you'll see that here. The magnitude of this peak is influenced by genetic and environmental factors, and the difference in peak bone mass between genders starts during puberty. Our peak bone mass is greater in males due to a more prolonged bone maturation period. And the result is larger increases in bone size and cortical thickness. So consequently, bigger and stronger bones in men. And as we just discussed, we know that bone size is 50 to 70% of our bone strength. So men are starting out with stronger bones. Our peak in bone mass is an important determinant for future osteoporotic fracture risk. So data from a Caucasian American cohort has shown that young men have bone cross-sectional area 30% higher and bone mass 20% higher than young women, both at central and peripheral sites. And our peak in bone mineral density occurs at age 20 in our hips and at age 30 in the spine. And as you'll see here, for everyone, will be followed by subsequent bone loss. So looking at a bit of a similar graph here, I want to talk a bit about bone banking. So this is something we want to think about when we're considering the lifetime effects of bone health and what our potential for a positive influence on bone health might be. So as we saw on the previous slide, 40% of total bone mass is accrued during the 2 years surrounding adolescence. So that's really the optimal time when we want everything to be in order to allow for maximum bone architectural structure to be formed. So in adolescence, just increasing participation in activity can increase our bone health. We definitely want to consider, nutrition and nutritional support in this time frame, but physical activity to actually stimulate the bone response is really critical. So we need to think about this as healthcare providers in terms of where do we have opportunity to advocate for physical activity in our youth. Osteoporosis is often considered a pediatric disease that is seen in older patients. So it manifests when we are older, but the deficits in what we have kind of put into our bone bank happen early on in life. So if we don't make those deposits into that savings bank, we have less to use throughout our lifespan. And as you see, we will all certainly be losing bone as demonstrated in this graph. So if we are not increasing our bone production during this time, we may find ourselves in an with insufficient funds as we age. Looking forward, what might we expect to see in the elderly in future decades and generations, um, given our kind of current state of decreased activity and increase in sedentary lifestyle in children and adolescents. So this is something that we want to think about. I don't know everyone's background, but if anyone is working in, a primary care setting or in a setting that allows us to have conversations with parents and, teens and children, just to express how important activity is to set us up for a better future for bone health. I think that can be really critical if we have the opportunities to have those conversations now. That's a really great opportunity for long-term prevention of bone issues. So we talked about previously, we're looking for a balance in bone resorption or breakdown and bone formation so that we can help our bones to grow strong. So bone turnover remodeling is that physiological repair process, and that really contributes to good bone quality. Resorption, on the other hand, is going to be the breakdown of bone that can occur. And so where we have an imbalance in resorption and formation, that's going to negatively impact our bone quality. So things that can affect that balance can be nutrition and hormonal factors, because those things can affect that mechanical response of our bones. And we'll take a little closer look at that. So that balance or bone homeostasis is related to how balanced that resorption and formation are. This is regulated by our hormones, calcium, and other external factors such as vitamin D. And you'll see examples on this table of influences on both the kind of wearing down process and the building processes. And you'll notice that vitamin D is actually seen on both sides of the equation here. So it increases the pool of calcium that's available for our neuromuscular function. And in fact, if necessary, it can even steal calcium from bones to help with those neuromuscular processes. So you'll find vitamin D in this column. But on the other hand, vitamin D provides stimulus for adequate absorption of calcium into the bone. So vitamin D is really an important factor in creating that balance. I think calcium insufficiency is always a thing that we're thinking about and connecting with osteoporosis and poor bone health. So calcium insufficiency actually diminishes the effectiveness of mechanical loading on the bones. And that loading is necessary to provide stability in our bone mass. Estrogen also determines those adaptive responses to mechanical stress. And so blocking of estrogen receptors impairs our bone formation response. And this is why we see increased rates of osteoporosis in women during menopause, because those hormonal changes decrease the sensitivity of the bone to mechanical loading. So there's a lot of influences that we need to consider when managing and making recommendations for optimal bone health across the lifespan, including nutrition, including good hormonal support. Another thing that we want to consider, in addition to nutrition and hormone support, is strain and biomechanics. So strain is defined as the force required to deform bone from an external source or physical activity or weight bearing. Strain magnitude would be considered the load of that strain. Strain distribution is the degree of strain in different bone regions. And then strain frequency would be the number of repetitions at which that strain is applied. So when that strain is consistently high, in our formation of bone exceeds resorption, that increases the mass and the strength of our bones. And this is the basis for specific strengthening exercise that can positively impact our bone health. We're talking about, we want that consistent high strain that exceeds resorption to grow our bones. But excessive strain actually can result in accumulated damage and fracture. And we want to find that balance of enough strain to improve bone health, but not creating micro damage. So we'll talk a little bit more about that when we discuss clinical applications and how physical therapy can be really beneficial for patients with osteopenia and osteoporosis. So now that we've talked a little bit about the pathophysiology of the bones themselves, I want to take a look at some specific contributors to osteoporosis in men. So general causes of osteoporosis. First, we have idiopathic osteoporosis. So this is just the development of this issue early on, before we would see kind of the abnormalities that we would associate with aging. This is often associated with a family history where both genetic and environmental factors might play a role. And this type of osteoporosis is actually less common in men. But this is an area where it is important to get a good family history, if that's possible, if our patients know their family history. So looking at whether their parents sustained a fracture that was not associated with trauma, asking those questions so we can get an idea of could this be contributing to risk factors. Secondary osteoporosis is something that actually results from another disease or condition or from treatment of that. So that might include the use of medication that interfere with our body's ability to produce new bone. So secondary osteoporosis is much more common in men than in women. And so these types of factors are things I'm going to be going into a little bit more in depth. So there are a variety of factors that can contribute to secondary osteoporosis in men. First, we're going to talk a little bit about the endocrine system. So we see a few things here that can be factors: glucocorticoid excess, hyperthyroidism, hyperparathyroidism, hypogonadism, and then type 1 and 2 diabetes. So I'm just going to talk a little more about a few of these. First, taking a look at glucocorticoids. So when we think about steroid use, what are we talking about? So I once had a patient who was actually in his 30s who ended up having to have a hip replacement due to a fracture that seemed to be of unknown cause. And he reported that he had been asked, multiple times by providers if he had used steroids. And he was always very adamant that, he denied being a steroid user. And this kind of went on until the day of his surgery, when one of the operative nurses was talking to him and sort of clarified, like, we're not talking about performance enhancing steroids, but, have you ever had them for allergies or, anything like that? And it was then that the patient kind of connected the dots and reported that he was an avid hiker. He did mountain climbing, rock climbing, and he actually had a really significant poison ivy allergy. And so over the years, he had many steroid injections in his hip. And so we want to be clear when we're asking these questions and taking these histories, what is that? What exactly is it we're talking about? We want to be specific with our questions. And we also want to consider other conditions where, steroids are commonly used as treatment. So autoimmune conditions such as rheumatoid arthritis, inflammatory bowel disease, ulcerative colitis, psoriasis, eczema. So getting those questions, that medical history to determine, hey, do we have a steroid use that's been ongoing that may be contributing to some bone health risk? So next on this list, we're going to take a look at hypogonadism. So looking at the idiopathic form of this, as we see in women, aging in men is also associated with a decrease in our sex hormones. So this condition is where for men, the testes are not producing enough sex hormones. This naturally, testosterone production decreases with advancing age. By the age of 60, 20% of men, and older than 80, 30 to 40% of men have serum levels that are not normal. And so in men, testosterone is produced by the testes and undergoes aromatization into estradiol. So as we age, the levels of both of those steroids change in parallel, and they're both going to be decreasing in hypogonadal men. So there's data that suggests that estradiol plays a key role in bone homeostasis or balance, just as in men, just as it is in women. Some studies have shown that estradiol replacement in men can actually prevent some of the increase in bone resorption. And other studies have showed that testosterone replacement showed similar results, although the effects were smaller if there was still an estradiol deficiency. So again, considering hormone support for these patients. In addition to the idiopathic hypogonadism, there are other causes of this. So bone health is actually an emerging concern in men receiving treatment for prostate cancer. This is a group of patients that I commonly see as a pelvic health physical therapist due to them having generally issues with urinary incontinence post-op prostatectomy. But we also address other issues that can be leading to bone health concerns as part of physical therapy. So 1 in 8 men will receive a diagnosis of prostate cancer in their lifetime. However, early diagnosis and advances in therapy currently result in an 85% survival rate. So while that is great, it raises importance of the long-term consequence of treatment, such as cancer treatment-induced bone loss, and that resulting increased risk of fractures. So continuous or intermittent androgen deprivation therapy, or ADT, is really commonly offered to men for prostate cancer. Gonadotrophin releasing hormone agonists and antagonists are commonly used, and those lead to a rapid and we discussed that can disrupt our bone remodeling. Studies have shown that bone loss in the first year of ADT is greater than the expected age-related loss. And it's actually greater than perimenopausal bone loss in women, which is at about 1 to 1.5%. In addition, glucocorticoids are often associated with cancer therapies. And as we've discussed already, that can add extra harmful effects when we're talking about bone health. Moving on to some GI disorders. So malabsorption syndromes, inflammatory bowel disease, such as Crohn's. Again, we're seeing steroid use further our bone health concerns. Moving to the bottom here, a population that has increased in probably the last 15 to 20 years are those who've had gastric bypass surgery. Those patients have actually lost the ability to absorb nutrients even when they are consuming them. And so they will often show significant decrease in calcium and vitamin D levels. Looking at patients who have chronic liver disease, this occurs due to decreased absorption of vitamin D, as well as increased bilirubin levels. For those that actually require transplant, you'll see here that their lowest bone mineral density is at 3 months post-op. So talking to these patients early on and doing some prior education is really critical to keep them kind of safe in their movement, to optimize their postures, to minimize stress that would put them at risk for fractures. So I would say this would be a really great time to refer patients for physical therapy, to address any balance concerns that we may have, to address any postural issues, and for them to get a lot of education on fall mitigation prior to the surgery. So this is something that we can have some recovery as far as that goes, but they are really at risk and vulnerable during this window of time. And so whatever we can do to mitigate risks by helping them with education and exercises is really beneficial. So some other factors that highly contribute to male osteoporosis, alcoholism, smoking. So can we have some conversations with patients about rehab or some smoking cessation classes? Kind of getting them that information can be really helpful. Again, looking at issues related to inflammation, COPD, these are contributing factors as well. And then we also have to take into account, what medications are our patients on that may play a role. So are they on PPIs? We've talked about cancer treatment, anti-diabetic medication. So all of these can be contributors and affect our bone health. And so I think that I've got a couple of nice little sort of summary tables here. Sometimes it's nice to have everything in one place, but just kind of reiterating what are some risk things we're looking at. So some secondary concerns, calcium, vitamin D deficiency. Are they having trouble absorbing nutrients? Do they have some inflammation that maybe is going to have them using some glucocorticoids systemically? 3 months plus is going to be a risk factor. Has the patient already had a fragility factor? If you've already had a fracture, your risk of fracture is currently at 100%. So have they already had some fractures? Family history of those fractures. And again, like we talked about, alcohol consumption, low BMI is a risk, and then tobacco use. And then just taking a little look here at some things we can do when evaluating patients. So really important to get that history, medications, and then some initial and secondary lab work that can give us a little more insight into what's going on with those patients. And then a few additional considerations. So when we are taking those histories, maybe we're talking to a patient who is athletic, they're active. They said, oh yeah, I've always been an athlete. But even having more specific questions to talk to them about, in adolescence, oh yes, you were an athlete. What kinds of things were you participating in? We generally consider participation in athletics to be protective, but we need to take into account were these weight bearing activities. So were they playing basketball? Did they play soccer? Or was this patient a cyclist or a rower or a swimmer, which may be less protective for their bone health. So we want to make sure that we know what we're talking about when patients are saying that they've been active. And another thing to consider, so cortisol negatively impacts bone health. High level stress over long periods of time will keep our cortisol levels high. So we need to consider our patient's background, maybe their work history, maybe living through the times of COVID. Having these high stress levels can definitely impact our bones. And so, are there things that we can do where maybe we can recommend mental health therapy or make those referrals to help them address stress that they're dealing with, and maybe learn some coping strategies to help with this? So, in this section, I want to talk a little bit about kind of application for some treatment strategies, and then also how physical therapy can aid in this. So, what we're looking for in clinical application is, we want a positive bone response, and we're trying to determine how do we apply those principles of stress and strain that we talked about earlier. So we've discussed that strain magnitude. That's kind of the load. But what we're looking for when we're talking about improving bone health is having that load be greater than what is habitual. So if I'm talking to a patient who's a walker, and let's say they walk, 30 minutes a day, doing more walking is not going to increase the strain magnitude. We need them to actually add additional load in order to get a positive bone response. So maybe for that patient, we might recommend something like a weighted vest. And I'll talk a bit more about that in a moment. Our strain rate here would be having that patient increase the speed of loading. So instead of just their usual 30-minute walk, we are going to say, okay, we need to increase that pace or that speed of the walk, or maybe even going into like a skip or a little bit of a jog. When we're looking at duration of exercise, they've done a review of evidence that actually shows that short duration is pretty sufficient. And there's more benefit to actually changing the magnitude than the duration. So we wouldn't necessarily want to tell that patient, hey, you need to walk 60 minutes instead of 30 minutes. That's not really going to benefit our bones as well as something would, like adding more, changing that magnitude. And for some patients, I have people that come to me and they say, okay, I walk 5 miles a day. And that's great. If they're also doing other things to improve their bone health. We don't want to have people that are spending all their time, increasing how long they're walking, and they don't have time for strength training, or they don't have the energy for strength training. So we may need to counsel patients on that a bit. So as I was talking about with a weighted vest, could be a good option for changing magnitude. Studies show that adding 5 to 10% of our body weight can be enough magnitude to assist with improving our bone density. So 5% of our body weight would be kind of a starting point. This is something that you would want to really gradually increase and have the patient just increase to tolerance with a maximum of 10% of the body weight. And these are things that are kind of readily available. You can order these kinds of vests on Amazon, and fairly affordably. Some other options of things that we can educate our patients on would be like surprising our bones. So doing things, a little different when we're out for a walk. So we can increase our pace for a period of time when we're walking. We can change directions, backwards or sideways, if that is safe for them to do. Or finding a route where they are having to navigate more hills. We want to look at trying to alternate this higher intensity exercise 2 or 3 days a week with lower intensity activity 4 or 5 days a week. That's kind of shown to be most effective. And so when we look at strength training, we want to look at magnitude versus frequency or duration. So studies actually describe an inverse relationship between strain magnitude and repetitions. What this really just means is that we want to do higher weight and lower reps. Okay. In strength training, we also want to consider site specificity. And we want to make sure that we are having multiplanar loading versus just single plane motion. So when we're talking to our patients about strength exercises, they can work with free weights, they can use weight machines at the gym or do some floor exercises in order to gain strength. We do need to explain to them that it's important to lift enough weight to stimulate bone growth. And because of that, they need to do fewer reps with heavier weights. So generally online, you can find calculators on different websites for like a 1 rep max. So patients can calculate their 1 rep max and then aim for about 70 to 80% of that 1 rep max when they're doing strength training. And like we talked about, we want to be specific with site of strengthening. So we want to target those areas that we discussed previously are most prone to fracture. So the spine, the hips, the wrists. And weight training is recommended 2 or 3 times a week. So for any of our patients for whom we have bone health concerns, so osteopenia, osteoporosis, just have risk factors, physical therapy can be a really great choice. As we know in healthcare, oftentimes spent that we get spent with patients can be really limited. And it can be difficult to give more than just general advice on exercise. I think that's a thing I hear from patients a lot is my doctor told me I need to exercise more, but they don't really know what that means. They really need a specific plan to feel confident in starting an exercise or strengthening program. So physical therapy has actually been shown to help improve bone health and prevent osteoporosis. Often a PT will have 45 to 60 minutes to spend with a patient. And I know that's time that physicians and nurses generally just don't have. A PT is going to take a really detailed history, including current activity levels, possible barriers to change, and then they can evaluate the patient for fall risks, balance, strength, posture issues, and then create a custom exercise program to help strengthen the bones and muscle over time. They can make sure that our patients are doing these exercises correctly. And again, we talked about that balance. We want to make sure there's enough strain that we are affecting those bones positively, but not so much that we're going to cause injury or, damage to the bones. So this can be a really great way to get people getting stronger in a safe capacity. Research shows that weight-bearing aerobic exercise and resistance training are beneficial for managing and preventing osteoporosis, and that good balance and posture exercises are important to prevent falls. And those are things that a PT can really help with. They can provide that evaluation and that specific guidance in all of those activities that we know will benefit our patients. So if you have patients that you're seeing, like I said, they're just at risk, they have osteopenia, they have osteoporosis, please consider referring these patients to a physical therapist for guidance so that we can help to build those bones, help to keep those patients safe, and help to prevent some of these, fractures and falls and mortality issues. Thank you all so much for having me and letting me come and talk today. Here's some information for you all if anybody had any questions or anything. But yeah, thanks so much for having me today.